Welcome to the deep dive. Today, we're tackling a really fascinating topic, epidemiology.
Right. It's basically the story of how we as humans track and understand health and disease in whole populations.
Exactly. Think about how we went from, being terrified by ancient plagues to now using things like AI to map diseases. It's really about learning to outsmart illness.
Absolutely. And epidemiology is kind of like that detective for public health, piecing together clues across time to keep us safe.
It asks some big questions, doesn't it? Like,
Uh,
how did people even start to grasp something like the Great Plague in London back in 1665?
or, fast forward to the early 80s, that mysterious illness popping up. Where did the first understanding even come from?
Yeah, those are huge historical moments, but it's relevant now too, right?
Totally. Why do some neighborhoods have higher rates of certain diseases, even if they seem similar otherwise? What are those hidden connections?
That's where epidemiology steps in, that public health detective work.
And that's our mission for this deep dive, to really explore what epidemiology is. Look at its origins, key moments, the methods used.
And how cutting-edge tech like AI is changing the game today.
Right, understanding how we get ahead of disease.
Okay, so let's get down to brass tacks, the definition. What exactly is epidemiology?
Well, the formal definition goes something like this: the study of the distribution and determinants of health-related states or events in specified populations.
Okay, hold on, that's a mouthful.
It is, and the
Yeah.
application of this study to the control of health problems.
Right, let's break that down. Distribution. What does that mean in plain English?
Distribution is basically mapping things out. Who's getting sick? Is it older people, younger people?
Right, cool.
Where is it happening geographically? Are there clusters? And when is it happening? Are there seasonal spikes?
So it's the who, where, and when, creating that health landscape picture.
Exactly, spotting those patterns.
And what about determinants? That sounds like the why.
That's it, precisely. Determinants are all the factors that influence health. It's a really broad category.
Like what?
Well, infectious agents, obviously viruses, bacteria, but also our genetics, lifestyle choices like diet or smoking, environmental factors,
Uh-huh.
and even social things like income level or access to education. Epidemiologists are digging for those causes, those risk factors.
So not just who's sick, but what's making them sick.
Okay.
And health-related states or events. That sounds pretty all-encompassing.
It really is. It's not just infectious diseases like flu or COVID.
Right.
It includes chronic stuff too: heart disease, diabetes, cancer, also injuries, mental health conditions, even positive things like why some populations live longer.
Anything affecting a group's health.
Pretty much, yeah.
And the last part, specified populations. How's that different from my doctor? My doctor cares about my health.
That's the key difference. Your doctor focuses on you, the individual patient. Epidemiology looks at the bigger picture, the group.
Ah, I see.
It could be a neighborhood, a whole city, a country, or even globally. The patient in epidemiology is the community, the population.
Okay, that makes sense. So with that definition, what are the main goals? What are epidemiologists actually trying to do?
There are basically four fundamental goals. First, describe the health status of populations.
Just counting things.
Yeah, counting cases, figuring out disease rates, tracking trends over time, answering questions like, how big is this problem and is it getting worse or better?
Okay, goal 1, understand the scale. What's number 2?
Second goal is to explain the causes of disease. This goes back to those determinants we mentioned.
Finding the why.
Exactly. What factors are making people sick or maybe keeping them healthy, getting to the root causes.
Makes sense. And the third goal?
To predict the occurrence of disease. Using those trends and risk factors, we try to forecast what might happen next.
Like predicting flu season.
Yeah, or how a new variant might spread. It helps with planning, allocating resources like vaccines or hospital beds.
Right, anticipating the future. And the last one?
The fourth goal is really the action part, to control and ideally prevent health problems.
Putting the knowledge to use.
Exactly. Using everything learned, the description, the causes, the predictions, to design interventions, shape policies, run health campaigns. It's about making a difference.
So it's a cycle. Observe, analyze, predict, act. It sounds like it's both learning and doing.
That's a great way to put it. It's a science of learning and a practice of acting for better public health.
Now, you mentioned this isn't exactly new. People have been trying to figure out diseases for ages, right? Even before it was called epidemiology.
Well, absolutely. The drive to understand and fight illness is ancient. The formal science evolved, but the core ideas go way back.
So where do we start seeing these early ideas emerge?
You can go back to ancient Greece around 400 BC. Hippocrates, often called the father of medicine.
Right, Hippocrates.
He made a huge shift. Instead of just blaming gods or spirits, he suggested looking at environmental factors.
Like what kind of factors?
In his writings, like On Airs, Waters, and Places, he talked about climate, water quality, even location affecting health.
That sounds surprisingly modern.
It was groundbreaking, suggesting natural, observable causes. He also really pushed for careful observation and recording what you see. That's foundational.
So moving away from the supernatural towards the environment, what happened after him? Did these ideas catch on quickly?
Well, progress was slow for centuries. Ideas about how diseases spread were pretty varied. The idea of contagion existed in some form.
Like diseases jumping from person to person?
Yeah. And in the 16th century, a scholar named Girolamo Fracastoro had this theory about seeds of disease.
Seeds of disease?
Yeah, tiny invisible things spreading through direct contact, indirect contact, like touching objects or even through the air.
Wow, that sounds a lot like germ theory.
It does, doesn't it? But back then it was just a theory. They couldn't prove it because they couldn't see these seeds. They were missing the microscope, essentially.
Right, the actual proof was missing.
Yeah.
So when did things really start to click?
A huge moment came in the mid-19th century. Dr. John Snow and the cholera outbreaks in London.
Ah, yes, the famous John Snow story. Remind us about London then.
It was pretty grim in some areas. Mid-1850s, rapid growth, but sanitation was lagging way behind. Cholera was terrifying, struck fast, often deadly.
And the main theory then was miasma, right?
Yeah.
Bad air.
That was the dominant idea, yeah.
But-
Foul smells causing disease. But Snow, he was skeptical. He didn't think it fit the pattern of cholera.
So what did he do differently?
He did some amazing detective work. During a big outbreak in 1854, he went house to house in Soho.
Really, door to door?
Yeah, asking where people who died from cholera got their drinking water. He was meticulous.
And he mapped it out.
He did. He created this now famous spot map marking each death, and what he saw was undeniable.
A cluster.
A massive cluster right around one specific public water pump on Broad Street.
The Broad Street pump.
Exactly. And his investigation showed that people using that pump were getting cholera at much higher rates.
What about people who didn't use it?
Well, he found interesting counterexamples, like workers at a nearby brewery. They mostly drank beer, not water from the pump, and they were largely spared.
That's pretty strong evidence. So what did he do with this information?
He took his map and his data to the local officials. It took some convincing, but he persuaded them to take the handle off the Broad Street pump.
Just remove the handle.
Yep. And guess what happened?
The outbreak slowed down.
It plummeted in that area almost immediately.
Wow. And this was all before they even knew about the cholera bacteria.
Exactly. That's what makes it so remarkable. It was pure epidemiological reasoning, observation, data collection, hypothesis testing, and then decisive action, a classic case study.
Incredible. So Snow really showed the power of this method. What came next?
Well, the next huge leap was the germ theory revolution later in the 19th century.
Pasteur and Koch.
Right. They provided the proof Snow was missing. They showed that specific microscopic organisms cause specific diseases.
Finally, the seeds of disease were identified.
Precisely. Now they knew why the water from the Broad Street pump was dangerous. It contained the cholera bacteria.
And that must have changed everything for public health.
Oh, massively. It led to huge improvements in sanitation, hygiene, understanding the need for clean water, and eventually vaccines and antibiotics.
The germ theory solidified things. But epidemiology didn't stop at infectious diseases, did it?
Not at all. As the 20th century progressed, especially after World War II, attention increasingly turned towards chronic diseases. Things like heart disease, cancer.
Which were becoming bigger problems as people lived longer.
Exactly. And landmark studies started using epidemiological methods to investigate these. Think of Dahl and Hill in the 1950s.
The smoking and lung cancer studies.
That's them. They clearly showed the link, demonstrating that the same kind of rigorous population-based investigation worked for non-infectious diseases too.
So the toolkit was adaptable.
Very adaptable. It expanded into nutritional epidemiology, like Goldberger figuring out pellagra was a vitamin deficiency, not an infection.
Right, I remember that.
And occupational health, looking at workplace risks. And more recently, a huge focus on social determinants of health, how poverty, education, racism impact health outcomes.
So the field just kept broadening its scope.
Constantly adapting to whatever the major health challenges were at the time.
Okay, so we've seen the history. Let's switch gears to the methods epidemiologists use today. What are the core concepts?
Well, fundamental is measuring how often disease occurs. Two key measures here are incidence and prevalence.
Right, incidence and prevalence. We hear those a lot. Can you break them down simply?
Sure, think of a bathtub filling with water. Incidence is like the rate the new water is flowing in from the tap over a period of time.
Okay, the new arrivals.
So it's the rate of new cases of a disease appearing in a population during, say, a specific month or year. It tells you about the risk of developing the condition.
Like the number of new flu cases last week.
Exactly. Now, prevalence, that's like the total amount of water in the tub at one specific moment in time.
All the water that's currently there.
Right. So it's the total number of existing cases, both new and old, in the population at a single point in time. Like how many people are living with asthma today?
So incidence is the flow, prevalence is the snapshot of the level.
That's a good analogy. Prevalence tells you about the overall burden of the disease right now. You really need both measures to get the full picture.
Okay, that clarifies it. What other rates do they use?
We also look closely at mortality rates, the rate of death in a population, and morbidity rates.
Morbidity being.
Illness or disability, the rate of sickness in a population. These help us understand how severe a disease is and whether our control efforts are actually working to reduce deaths and illness.
Got it. So those are the what and how much. How do they investigate the why, the causes and determinants? What kinds of studies do they do?
There's a whole toolkit of study designs. Broadly, you can divide them into observational studies and experimental studies.
Observational versus experimental. What's the main difference?
In observational studies, the researchers basically just watch. They observe what's happening naturally without intervening or assigning exposures.
Okay. Like watching from the sidelines.
Exactly. Two really common types are cohort studies and case control studies.
Tell me about cohort studies first.
In a cohort study, you identify a group of people, the cohort, and you follow them over time.
Okay.
Within that group, some people will naturally have a certain exposure. Maybe they work in a specific industry or have a particular diet, and others won't. You track everyone to see who develops the health outcome you're interested in.
Like tracking smokers versus non-smokers to see who gets lung cancer.
That's the classic example. You compare the rate of disease in the exposed group versus the unexposed group to see if the exposure is linked to the outcome. You're looking forward in time.
Okay, following groups forward. How do case control studies work then?
They work backward, in a way. You start with people who already have the disease, the cases, and you compare them to a similar group of people who don't have the disease, the controls. Then you look back at their past history to see if there were differences in their exposures.
Like asking people with food poisoning what they ate compared to people who didn't get sick.
Exactly. You're trying to find out if a past exposure was more common among the cases than the controls. It's efficient for studying rarer diseases.
So cohort is forward, case control is backward. What about experimental studies? You said researchers intervene there.
Right. In experimental studies, the investigator actively does something. The gold standard here is the randomized controlled trial, or RCT.
We hear about RCTs a lot with new drugs or vaccines.
That's their main use. You take a group of people and you randomly assign them to either get the intervention, the new drug, the vaccine, or to a control group.
The control group gets a placebo, or the old treatment.
Usually, yeah.
Yeah.
A placebo or the current standard treatment. Then you follow both groups and compare the outcomes.
And the randomized part is key.
Crucial. Random assignment helps ensure the groups are as similar as possible to start with, so any difference in outcome is more likely due to the intervention itself, not some other factor. It minimizes bias.
Okay, so RCTs actively test something. And through all these studies, the goal is often to identify risk factors.
Absolutely. A risk factor is anything, a behavior, an exposure, a genetic trait that increases the likelihood of developing a disease, like high blood pressure for heart attack risk.
And finding those is key for prevention.
Totally. If you know the risk factors, you can target interventions to reduce them.
And underpinning all of this is data. Lots and lots of data.
Oh yeah, epidemiologists are data detectives through and through.
Where does it all come from?
All sorts of places. Surveys, medical records, lab results, death certificates, insurance claims, public health surveillance systems.
It sounds like a huge amount to sift through.
It is, and that's where statistical methods come in. We use stats to find the patterns, the associations, the trends in that data. Good, clean data is absolutely the lifeblood of Epi.
Okay, so that covers the core methods. But things are changing fast, aren't they? Especially with AI and big data entering the picture. This feels like a major shift.
It really is. We're in another transformative era for epidemiology, maybe as big as the germ theory revolution in some ways. AI and the ability to crunch these massive data sets, it's opening doors we couldn't even peek through before. And yeah, as of today, May 9th, 2025, this is happening now.
So how is AI changing things on the ground? Like disease surveillance, tracking
Well,
outbreaks?
AI algorithms can now ingest and analyze just incredible amounts of diverse data in near real time.
What kind of data are we talking about?
Think way beyond traditional hospital reports. We're talking news articles from around the globe, social media chatter about symptoms.
Wait, social media? Really?
Absolutely. Sales data for over-the-counter meds like cough syrup, data from wearable fitness trackers, flight passenger data, environmental sensor data.
That's a lot.
It's a staggering amount. And AI can sift through it at speeds humans just can't match, looking for anomalies, unusual clusters, spikes in keywords, things that might signal an outbreak starting.
So it could give us an earlier warning.
Potentially days, maybe even weeks earlier than traditional methods that rely on waiting for official reports. It's like having this incredibly sensitive global listening system constantly scanning for threats.
That's huge for response time. What about prediction? Can AI help forecast disease spread?
Definitely. By feeding AI models historical data, current trends, maybe mobility data, environmental factors, they can generate forecasts for how things like the flu or maybe new COVID variants might spread.
And that helps public health officials how?
It helps them be proactive instead of reactive. They can use those forecasts to decide, where to preposition vaccines, ensure hospitals have enough beds, ramp up testing in certain areas. It allows for much smarter resource allocation.
Moving from reacting to predicting. That's a big change. Are there other ways AI is contributing?
Yeah, another major area is uncovering really subtle patterns and risk factors, especially for complex chronic diseases.
How so?
Well, think about something like heart disease. There are so many potential contributing factors: genetics, diet, exercise, pollution, stress, social factors. AI can analyze data sets with thousands of these variables simultaneously.
Something a human brain just can't juggle.
Exactly. It might find complex interactions or identify entirely new risk profiles that weren't obvious before. This can spark new hypotheses about what causes disease and lead to more personalized prevention.
And I guess visualizing all this complexity is also easier with AI.
For sure. We're moving from static charts and maps to dynamic interactive dashboards. Researchers and policymakers can drill down into the data, watch trends unfold in real time, see disparities between groups much more clearly. It makes the data much more accessible and actionable.
It sounds incredibly powerful, almost like epidemiology on steroids.
That's one way to think about it. It's really augmenting the epidemiologist's capabilities, providing much more powerful tools to tackle population health challenges.
But are there downsides? Challenges with using AI like this?
Oh, absolutely. There are significant challenges we need to navigate carefully. Data privacy is a huge one.
Right, dealing with sensitive health information.
Exactly. We need really robust ethical frameworks and strong data protection measures in place. Then there's the issue of algorithmic bias.
Bias in the AI itself.
Yeah. If the data used to train the AI reflects existing societal biases or health inequities, the AI might actually perpetuate or even amplify those disparities.
So it could make health inequities worse if we're not careful.
It's a real risk. There's a lot of focus right now on ensuring fairness, transparency, and equity in how these AI tools are developed and deployed in health.
So powerful tools, but they need careful handling.
Definitely. AI enhances human intelligence. It doesn't replace the need for critical thinking and ethical oversight.
Okay, looking forward then. Where do you see epidemiology heading in the next, say, 5–10 years?
Well, it's always evolving, right? But I think we'll see a much stronger push towards what some call personalized public health.
Personalized public health. What does that look like?
It means moving beyond one-size-fits-all recommendations. Using things like individual genomic data, maybe data from your smartwatch, combined with AI insights to tailor prevention advice or interventions more specifically to your personal risk profile or the profile of smaller subgroups.
Interesting. More targeted approaches. What else?
Genomic epidemiology is going to keep exploding. Analyzing the actual genetic sequences of viruses or bacteria during an outbreak.
What does that tell us?
It lets us track the spread with incredible precision, see how the pathogen is evolving, maybe developing drug resistance, and it helps design more targeted vaccines and treatments based on those genetic fingerprints.
And given everything we've seen recently, I assume the connection between human animal and environmental health will be central.
Absolutely critical. The One Health concept, recognizing that our health is totally interconnected with animal health, and the environment is only going to become more important.
Because so many new diseases jump from animals.
Exactly. Things like COVID-19, Ebola, many strains of flu. They're zoonotic. So epidemiologists need to work hand in glove with veterinarians, ecologists, climate scientists to anticipate and prevent those spillovers. Collaboration is key.
It sounds like the future is complex, interconnected, and very data-driven.
It is. But, amidst all this new technology, the AI, the genomics, the core principles of epidemiology haven't changed.
The fundamentals remain.
Absolutely. Rigorous observation, careful data collection, sound scientific methods, critical thinking, and acting on the evidence. Those remain the bedrock. The future is about blending those timeless principles with these incredibly powerful new tools.
So we've journeyed from Hippocrates looking at water quality, through John Snow removing a pump handle, the germ theory revolution, tackling chronic diseases, and now into this era of AI disease mapping. It's quite a story.
It really is, and the thread running through it all is that fundamental human desire to understand why people get sick and what we can do about it. It's this blend of scientific curiosity and a real drive to alleviate suffering.
A combination of hard science and public service.
Exactly. And it's work that has genuinely saved millions upon millions of lives and continues to guide us through health challenges, old and new.
And it seems like its mission is only becoming more vital in our connected world, especially with these new tools amplifying its impact.
Couldn't agree more. The core mission, describe, explain, predict, control, is as relevant as ever, and our ability to pursue it is growing stronger.
Well, thank you so much for taking us through this fascinating deep dive into epidemiology. I hope everyone listening has gained a new appreciation for this field.
It was my pleasure. And if you found this interesting and want to keep exploring topics at the crossroads of science, data, and society, do consider subscribing to The Deep Dive.
Yeah, and please share this with friends or colleagues who might be interested. We'd also love to hear your thoughts.
Definitely. What part of epidemiology's story, or maybe its future with AI, stood out most to you? Let us know in the comments.
Until next time, stay curious.
And remember, understanding the patterns of health really is the first step toward building a healthier future for everyone.